U.S. healthcare is going digital, so you'd kind of expect that electronic medical records could talk to one another. Alas, the healthcare system's still a veritable Tower of Babel. It's a real mess for patients and doctors, the hospitals and labs when they're trying to share information. The pandemic has actually made things worse as people get testing and care in different places than they're used to. But thanks to healthcare, the fax machine is still alive and well into the 21st century. But people like Drew Ivan haven't given up. They're working nonstop to turn the promise of healthcare interoperability into reality. As Chief Product and Strategy Officer of Lyniate, Drew's building digital connections throughout the healthcare ecosystem. I'm your host, David Williams. Thanks for tuning in, and remember to subscribe to HealthBiz. Well, Drew, welcome to the show today.
Thanks for inviting me.
So tell me about your background.
Sure. So today I'm the Chief Product and Strategy Officer at Lyniate, but I didn't sort of start off aiming at that goal. I started out as a software developer, and I worked in a couple of other industries prior to healthcare. In fact, shortly before I got into healthcare, I was working in the IT department of a headhunting company during the dotcom boom. So we were taking executives out of traditional hardware and software companies and placing them in these dotcom startups, most of which were destined to fail. And as the dotcom boom ended, I started looking for a different career or different industry to work in, and I landed almost at random at a small EMR company. And I was attracted there because I wanted to work in Java as a software developer, not because it was healthcare. But after I was there for a while, a year or two, I realized that working on software that helps doctors treat patients is a lot better for the world than working for a headhunter, which was taking successful executives out of big companies and putting them on a path to to a dot-com disappointment. So I felt good about that change, and ever since then I've been in the health IT sector, just because it's not the flashiest or most attractive, but it's working on a problem that's important. The healthcare system needs a lot of attention, and so that's kind of where I want to put my effort.
The .com, it was an interesting time to be probably in the headhunter role. It was kind of like during the gold rush, the guys selling the pickaxes and the shovels, and didn't really matter if there was gold in the ground as long as everybody was eager to be moving around and doing some of these things that didn't seem exciting, but at least that's where the action was, and maybe that's where the gold was.
Yeah, and unfortunately, it really skews your perspective, right? Because if you're a company that is on a modest growth path, and then just because you happen to be serving customers that are exploding, then that means you're selling a lot more pickaxes. And one of the problems that we had was we didn't discern between like the industry movement and our own business acumen. I mean, we thought it was because we were geniuses that we were thriving, and in fact, it was because we were riding this wave that wasn't permanent.
Yeah, no, it actually passed remarkably quickly in retrospect.
Mm-hmm.
You know, I remember the mantra then that was sort of, get big fast.
Yep.
So you just had to kind of go as fast as you possibly could. That was one of the things that people wanted to do. And, there were some weird things like revenue didn't matter and, all sorts of crazy things. We worked at the time with a company that had 100 salespeople, and but they didn't have any sales. The founder said, "A good salesman pays for himself." But this is like it didn't really make a lot of sense. But
Yeah.
I'm glad you're past that. So at this point, with the .com boom in the rearview mirror, you've been in health information technology for quite a while,
Yeah.
and there are a lot of changes that have occurred. Then, of course, when you got into it, was before the High Tech Act. It was before the Affordable Care Act, before a lot of things that have occurred. So, what are some of the kind of the big picture changes you've seen over your years in health IT?
Yeah, and you've named some of them. I got into health IT in in 2000, so that's about 20 years ago. And at the time, I worked at a small EMR company, and there was no leader in EMR space then, like there is now. There were I was, from a competitive intelligence standpoint, I was tracking something like 300 EMR companies.
Yeah, that's the number I
Um,
remember.
yeah, and I mean they were micro targeted at specialties and geographies, and so there was a lot of companies out there, and we were just one of the 300. But we were in the same starting blocks as the industry giants today, and that's what I mean. It was kind of a hangover from the dot-com boom. We saw that there was a lot of potential for fast growth there. I thought that the next thing was going to be EMR is going to be the next thing, and this is day one of what's going to be a $1 billion industry, and it was. It's just just that it wasn't our product that was at the front. But part of what I focused on in the EMR context was interoperability, which is what set me down the path I'm on today. But that reflects some of the changes. Over 20 years, we've seen EMR adoption go from almost nothing to almost 100%. We've seen interoperability go from being a nice to have feature to being kind of the starting point of any conversation. And those are two of the macro trends. Um, you know, I think that if we had taken a snapshot of today and sent it back in time 20 years, it would have been very recognizable, right? I mean, the whole reason we were building EMRs was because we expected universal adoption. We expected data liquidity. We expected, all the analytics and easy transfer of information that comes with getting data off the paper charts and into a computer system. What I don't think we would have recognized is some of the side effects or second order effects. Just because the data is electronic doesn't automatically make it interoperable. There's still effort to do, and there's still going to be resistance, right? There's not necessarily a business motivation to have interoperability, even if there is the technical capability. And then the final thing that I would point out is patients are getting in on the act today. The whole concept of the recent ONC and CMS rules is to extend interoperability beyond the organization to organization communications and get that data out to patients, which maybe it was obvious to somebody 20 years ago. It was not obvious to me that patients would ever care about their medical records, because we had the impression at the time, a medical record is a thing that lives in a manila folder in your doctor's office. It's full of information that you can't understand as a layperson. Why would you even want to look at it? And that's different today. I think there's a use case for combining that clinical information with consumer information or fitness information and doing interesting things with it, out at the edges on the patient's mobile devices, for example.
Well, I think that, as you mentioned, even 20 years ago, we were talking about interoperability. I think at the time, assuming that when we took things from paper and made them electronic, we would enable that almost automatically. I don't think anybody thought it was completely automatic. And I remember during that time talking to one person who was actually the president of the Mass Medical Society at the time, and he was lamenting the fact that he and his partner had the same EMR. They were in the same office, but they couldn't actually share a record. At that point, it was just one account per, and it was just maddening. So we've seen that one coming for a while, and certainly we're going to talk about interoperability a little bit later on, which I know has been a big focus, and looks like we have. I guess I'll be disappointed in 20 more years if we come back and we're still saying I didn't know, in 2020 that it was going to take till 2040, but maybe we'll go a little bit faster. Let's talk about something that's right kind of in the immediate moment, which is of course, the COVID-19 pandemic.
Mm-hmm.
And, as I mentioned, we'll get into sort of interoperability more broadly, but what kind of impact has the pandemic had on kind of the course of health information technology?
Yeah. So for that, I guess I'll make a few points. One is that COVID is a big impact, and it happened fast, relatively quickly, which means we didn't really have time to invent new technology or new solutions to combat it. We had to go forward with the technologies that we had, and there was no anti-pandemic technology that we had built. But there were a lot of useful technologies that we didn't have to invent because they already existed. And those are the technologies that we've seen go on a skyrocket in terms of adoption or utilization. And they're things that you would expect, things like telehealth, video conferencing, prescriptions by mail. Basically, anything that reduces person-to-person contact is something that's been changed forever by the pandemic. The other thing the other area where we're seeing a lot of adoption is in terms of keeping track of data related to the pandemic. So things like tracking supplies and where are the ventilators, where are the doctors, where's the staff, where's the supplies, and then where's the virus. Electronic lab reporting of results is something that has been done for a long time between the laboratories and public health agencies, but the volume of data changed drastically in the past 8 months. We're at an interesting inflection point because we're coming up on a year of living with COVID, and a year is long enough to start inventing new technologies. And it's not clear to me what those are going to be. I haven't seen them yet. We're still sort of in the phase of fighting the battle with the weapons we have. But I think the pandemic will be with us long enough, and we'll want to be prepared for a potential next pandemic in such a way that there is space for those technologies to get born and cultivated in time for the next one. And like I said, I don't know what they are, but it'll be interesting to see them emerge.
I think it's an interesting observation that people are beginning to understand now that the pandemic isn't just going to suddenly leave us. I think at the beginning it was so dramatic back in March or so that figured this could only be a few weeks or months or whatever. And people just didn't look out that far, and then you sort of keep pushing back the expectation for when things are going to be quote unquote back to normal. And then a realization that vaccine has limitations, even a good one. The therapies aren't really working as well as we might think, and so on and so forth. So the
Mm-hmm.
pandemic is going to be with us long enough to change habits and long enough, for new technologies to be developed if we can figure out what they are. Going back to something you said earlier about kind of the consumer, the patient's interest in their own medical record. Certainly one of the things that's happened now is everybody has a smartphone, broadband internet connection, and so on, and more of a sense of consumer empowerment within healthcare. So in March, all the physician offices suddenly went to telehealth. They had the capability, but they hadn't really used it. But then they had to do it, and they were reimbursed, and the patients were liking it in general for most things. Now you see, was interesting, a bit of a swing back toward the in office that might be more kind of provider centric than patient centric. So I think it'll be interesting to see kind of the interchange between the patient demand and what the providers want to do, and how I think that will evolve differently in different practices. Maybe that will lead to some of the technology innovations that you're thinking about for COVID.
Yeah, I think that's a good point. Is that we did see that initial, switch from 100% in office to 100% telehealth, and now it's coming back a bit. And I guess the ideal situation is we would use the right setting for every encounter. Sometimes you need to be in the doctor's office because he needs to, physically examine you. Sometimes it can be virtual, and wouldn't it be nice if we could offload a lot of those encounters to an easier setting for both the provider and the patient?
So now let's get to talking about interoperability. It's a term that you started using early in the podcast, and one that you've been talking about for a long period of time. Maybe we could just start off by kind of a definition or working definition for interoperability and talk about why it's important.
Yeah, I mean, generically, interoperability means getting two separate systems to work together, ideally without them knowing anything about each other beforehand. In other words, if you have two pieces of software and you're determined to make them work together, you can do it. But it's not really interoperability unless they're using some sort of standards or some sort of a method by which the integration is much easier. But what I found, and actually we just had our user group last week, and I gave a long talk about this. Interoperability means different things to different people and at different times. Because if you go by that definition, anytime you get systems talking to one another, you have interoperability. And one of the first ways we used it in healthcare was to submit claims from providers to insurance companies. It's been since I think the late 90s that most of those claims were electronic, and so we had interoperability in the 90s. And something you said before is something that comes up over and over again, which is, you know, every time we reach a milestone in interoperability, we still have the question, why don't we have interoperability yet? Because by the time we reach that milestone, we've already set our sights on the next one. And so once we were able to communicate between providers and payers, we started thinking about, well, can we get all of our clinical systems to talk to one another? And once we did that, then we started thinking about, can we get all of the hospitals in a region to talk to one another? And then we invented HIEs, and we had that type of interoperability. But the question of why don't we have interoperability yet was still around, because now we wanted to think about how do we get data out to the patients, and that's something that we're still working on. So every time we solve an interoperability problem, there's another one on the horizon, and so that's going to be an evergreen question: is when will we have interoperability? Which is good, right? I mean, it's job security for
Sure.
for everyone in the interoperability sector, but it means that we're solving harder and harder problems over time. But my key point is that there's not one definition of interoperability, so that we can't say, we did it, we built it, we're done with it, we never have to think about it again. It's a journey, not a destination.
One of the good things about being in the health IT space is that sometimes you can look at other industries that take on IT a little bit faster, like financial services is one that's often pointed to. And I think about, ATMs. When you first had the card, you could only use it in certain places, and then they've long since become, nationally or internationally interoperable. At the same time, though, you can't just kind of transfer your bank account from one place, one bank to another. It's not as though it's unlimited. And you think about airlines, on the one hand, there's a lot you can do. On the other hand, there used to be just as much sort of, interlining or whatever they called it. And now the systems are maybe less connected than they were in the past. So it's probably not healthcare that is the only problem there. So, we talked about what interoperability is, why people want it. Any specific things related to the virus and the pandemic of where interoperability takes on a new hue?
Well, where we're seeing it is what I talked about before with lab result reporting, because we have a number of laboratories that are our customers and a number of public health departments. And what we're finding is that they need to add capacity, and that means number of reports coming from the labs to public health, but it also means number of labs that are reporting. A lot of the testing capacity that we put in place for COVID was built on labs that were not doing COVID testing before, and never had to report to public health for whatever reason. So we're seeing a lot of new interfaces being built along those lines. We're also seeing, obviously, if you implement or scale up a telehealth solution, you need to integrate that to the other systems in the hospital, like especially your electronic medical record. And so there's a driver for integration there. So those are some of the places where we're seeing interoperability be impacted. The other place is just in terms of like I talked about before, tracking where the resources are, people and the equipment. That's something that didn't have a good interoperability solution before, and it kind of still doesn't. I mean, we're starting to work on some standards for moving that data around, but the standards definition process is a slow one. What you saw was the Department of Health and Human Services was telling hospitals to, I'm oversimplifying this, but they basically said, update a spreadsheet every night that tells us how many ventilators you have, how many beds you have in use. And I mean, when the solution to an interoperability problem is to have everyone update a spreadsheet every night, you've probably identified an opportunity to build something a little more clever.
Well, I do think that there's interoperability sort of within an institution or within a health system. So if I'm going to have interoperability between, let's say, my primary care office, my specialist, and the hospital, that's all part of one system. That's one thing, and that's hard enough. But then if I need to go across systems. So if I'm in Boston and I'm going from Mass General over to Beth Israel, that's a harder problem, even if I'm in the same area. And maybe it's the same sort of thing when you're talking about, public health and looking at resources at a system level, because at a kind of across different healthcare systems. So they might have the asset tracking, for example, within a hospital, but to be able to combine that with data from somewhere else has really been kind of lacking.
Yeah, that's exactly right.
I want to ask you about this point about all the test results. Obviously, there were no COVID-19 tests being done a year
Mhm.
ago, and now there are. We're supposed to have millions a day. So there's a lot. Now, one of the phenomena that I've seen, and you mentioned it, is that there's more labs doing the tests, more places to report to. So there's all these new nodes that are out there, and there's a ton of faxes going by, which
Mhm.
is my understanding. And that's one thing to say, okay, let's set up the interfaces and make it work. But my understanding is also that even when there are interfaces, people may not know about them, or they may be kludgy, and you have interfaces plus you have faxes. What's going on with that, or am I wrong?
No, that's actually unfortunately quite right. That I mean, the way public health reporting works is that when a provider, and that covers doctors and laboratories, anyone who's providing healthcare, when they detect a certain condition that's reportable, they are compelled by local laws to report it to the public health department. And historically, this has meant things like hepatitis, or if there's a smallpox case. It's infectious diseases for the most part, or foodborne outbreaks. Anything that the public health department wants to track. There's usually a list of about 50 conditions that are reportable to the public health department, and there's different time scales and different methods that are acceptable for making those reports. But since the providers are mandated to do these reports, the public health departments generally tend to try to be very flexible about how they accommodate those reports. They don't want to specify, you have to send an electronic lab result to a provider who's maybe, a one doctor practice who doesn't even have a lab interface.
Yeah, but they have a fax machine though.
Yeah, exactly. So the law says they have to do the report. It doesn't say how, and the public health department doesn't really want to enforce that. Now they do try to get as many automated results as they can, because if they're getting a feed from a large laboratory that does tens of thousands of tests a day, it makes sense to build that lab interface. So they're moving to electronic reporting as much as they can, but because it's always been fairly low incidence. There's not that many cases of smallpox or hepatitis or these infectious diseases. Fortunately, they're low volume interfaces. It doesn't always make sense to build a full time electronic lab interface. Which obviously that changed really rapidly when there was a requirement to report COVID results, because there's thousands of those every day. So you saw all these interfaces that, if they were built at all, they were designed for a few reports a day, suddenly having to handle volumes of thousands per day. And it's just, the system wasn't designed for that. And so, in order to make sure that no reports were missed, there was just an agreement that, let's get the results by whatever method we can. And if that meant you do a dump of all your results out of your EMR every night and send us that file. If that's the best you can do, then you're gonna get duplicates every day, right? If you're always dumping all your results, then your file gets bigger and bigger every day.
Yeah.
And these are the kinds of things that we're seeing our customers deal with as the outbreak starts up. And so it's a huge challenge, right? Because of what I said before, if you're solution is designed for a small volume of results, and you suddenly have to increase the capacity 1,000-fold, you're going to see some rough edges on that. And I think we're doing a good job as an industry and a country in terms of reacting to that, but it's not as fast as we would like, and it's not as smooth as we would like. And part of it, you can attribute it to chronic underfunding of the reporting infrastructure.
Right.
We've never had a need to be able to expand this rapidly before, or to this magnitude before, and so we just haven't built the infrastructure to handle it.
Right. Although, as Bill Gates will tell us, it was entirely foreseeable, so we should have had the infrastructure in place.
Well, I agree, and there was some movement toward funding public health infrastructure prior to the pandemic, and almost unfortunately, that got superseded by the funding that came with the pandemic. Right? We suddenly dumped a whole bunch of money on this problem, and it got lost that we were trying to do it in a planful way.
Yeah.
But you're right. I mean, or Bill Gates is right. We should have done it 10 years ago, or something.
Yeah.
Yeah.
So I want to ask you about Lyniate in a moment, but One question is about kind of the 21st Century
Mhm.
Cures Act and other things that are going on from the federal level in terms of codifying interoperability. I know there's some final rules that were issued and they may be delayed in terms of their implementation, but how does all that play in?
Yeah, it's interesting to watch because uh, one side effect of being in the health IT industry for 20 years is that you sort of follow the federal policy as it unfolds over a long period of time. And what we saw was, the Meaningful Use Program started in, I want to say, 2008 or 2009, which funded subsidized EMR purchases for providers. And like we talked about before, I think there was an implicit assumption there that if we just got everybody on an electronic medical record, the interoperability would follow almost automatically. And that turned out not to be true. And so 21st Century Cures is actually an omnibus bill that has a lot of really interesting healthcare initiatives in it. But one of them is to sort of repair this oversight of the interoperability piece. And so, it says it says that you can't block information, whether you're a vendor or a provider. If the patient wants the information to flow, it has to flow, and it puts in penalties for information blocking. And at the same time, it says, we'll establish a convention by which this information can flow. And that was written in 2016. It took until 2020 to figure out exactly what that means. But what it ended up meaning was every provider and every payer has to expose the data about their patients or members as FHIR APIs, which is going to take us to a new place in terms of interoperability. API style integration is different from the types of integration we've done in the past, and it enables different types of workflows. And I mean, I think it's a better fit for the communication to the patients or members, because most of what they want to do will be on their mobile device, and a mobile device connection to a REST API is a pretty natural fit. That's how all your other apps work. So the fact that healthcare data will be supplied in a similar format means that it'll be hooking into like a development style that's already widely accepted in terms of the use case that we're trying to enable. So I think that'll be good.
Good. I have a lot of enthusiasm and optimism for the coming few years. So let's make the most of it. So speaking of that, so your company is Lyniate, and you've got Rhapsody and CorePoint, all kind of cool names of things. How does this all fit together? What are you doing? How does it relate to our discussion been having here on interoperability?
Yep. So Rhapsody and CorePoint are both products that are in the class of what we call integration engines. And the most common use case is for a hospital or a provider to install this technology and use it to tie their internal systems together. The same technology can be used to communicate across organizations, or it doesn't have to be providers. It can be payers. It can be public health. It can be all sorts of care settings. It's really focused around the healthcare standards for communicating data. And historically, Rhapsody and CorePoint were separate companies with competing products in the market. But we merged the companies a little over a year ago, and so now we have both products, which gives us a broader perspective in terms of the types of customers that we serve. Um, but we definitely do have two products that are very similar in nature and serve the healthcare industry.
No, it sounds good. And I assume picking up on all the various trends that we've talked about here, and you've seen sort of a shift of things with the pandemic, or if you look back in 2 or 3 years, it'll just be sort of a blip on the radar. Or how would you expect it to have influenced the evolution of the company?
It's been interesting in a lot of ways. One thing that the pandemic did was make everybody work from home, which surprisingly accelerated our organizational integration. As I said, we were merging two companies that had historically been competitors, which comes with a lot of organizational challenges and cultural challenges. But as soon as everybody was sort of on the same side against the pandemic and trying to ramp up on working from home, it really cleared a lot of the obstacles out of the way and helped us along the integration path.
On the work from home point, one thing that certainly happens with IT, and I'm assuming with interoperability, it could be, if anything, accelerated, are challenges in terms of cybersecurity. And I'm wondering how that ties into interoperability, if it's a barrier to it, if some of the things that you're doing actually helpful, a cloud infrastructure versus on premises. How do you think about
Yeah,
cybersecurity?
all of that. So cybersecurity was on our radar before the pandemic, but which is good because when the pandemic came, we sort of already had a plan in place. And our plan was there was two parts of it. One was to increase our internal cybersecurity stance, which obviously became very important as people started working from home. The other was to start to increase our cybersecurity capabilities for our customers. And that meant building features into our products and also offering services to our products. So we're starting to partner with some cybersecurity companies because we think that a lot of our customers are certainly interested in keeping their healthcare data safe and would be interested in services and product features around cybersecurity. So for sure, the pandemic accelerated our plans in that area. Luckily for us, we did have some thought that we had already put into it.
So it sounds like you've been super busy, not surprisingly, but maybe a little bit less of a commute. So have you had a chance to do any pleasure reading over the past few months, or if not, anything you're hoping to read?
I have. One of the books that I read a while back was called Thinking in Bets by Annie Duke, and she just released a sequel to it called How to Make Decisions. And both books are about sort of quantifying the drivers that go into decisions and predictions, so that you can better understand how to decide among them and how to prevent yourself from falling into the common traps that people fall into about deciding which course of action to take or evaluating courses of action once they've been taken. So that's what I'm in the middle of at the moment.
No, it sounds good. So that's two books I got to get to then. Well, Drew, thank you so much. It's been a real pleasure speaking with you today. I wish you nothing but the best in the push toward interoperability, and we'll do the next podcast, less than 20 years from now, but hopefully I've made some progress.
Awesome. Thank you.
You've been listening to the Health Biz Podcast with me, David Williams, President of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.